Thank you, David, and thank you, Rami and Serge, for inviting me to talk about the optimal use of lenalidomide as therapy for MDS. So, like David mentioned, I know Rami covered this a little bit in his How I Treat MDS section. And again, this is one of the 3 drugs that has a US FDA label for the treatment of MDS, but it is kind of a subset. So this little schematic here kind of represents all of MDS. And so specifically for lenalidomide, the label says transfusion-dependent anemia due to low or intermediate 1 risk MDS associated with del(5q) abnormality plus or minus additional cytogenetic abnormalities. And that is cut and paste from the label. But for the purposes of this talk, I'm going to use this little bit of this diagram to help guide us through here. And it may seem like an honor roll of studies or kind of this study, that study, MDS 1, 2, 3, 4. But really the reason I'm kind of going in this process is to really point out the different populations of patients and the results of using lenalidomide in each of those populations. So really the label focuses on this particular box here, lower risk MDS that has the del(5q) abnormality. So this is of course not to scale. The isolated del(5qs) are about 7 to 10% of all patients with MDS. Del(5q) plus 1 other cytogenetic abnormality is somewhere around the neighborhood of 3% of patients with MDS. And those with del(5q) and a complex cytogenetics are somewhere in the 5 to 10% range. So Rami also already mentioned the MDS 003 study. So we're going to start at the most logical place, the middle. But this was not the MDS 1 study or the 2 study. But this was the study that did lead to the FDA approval of this medication. And this study looked at a little bit bigger population. So the red box there is a little bit larger. It included lower risk and higher risk MDS, those with the del(5q) abnormality plus or minus other abnormalities on the cytogenetics. And these patients were all red cell transfusion dependent. And they all received lenalidomide, 10 milligrams daily, 21 of 28 days. And the study was later amended for a full month, a full cycle of lenalidomide. On the right-hand side of this slide are the infamous Table 1, the patient demographics. And you can see, if you kind of scroll down towards the bottom there, Fab type and then the IPS risk category. So in the Fab type, there were quite a few patients with refractory anemia and excess blasts, 20% of patients. And in fact, there were some patients with AML, a patient with AML that snuck in there, and a few other rare diseases, so atypical CML, and then those that the inadequate specimens too. So mind you, this is maybe a little bit higher risk population than what the label would indicate. But nonetheless, this was a relatively positive study, as you can see. Table 2 there in the upper left-hand corner are the response rates. And so the far right column is the total patient population of this study. So those who had transfusion independence, 67% of patients, transfusion independent in the study. And an additional 9% had at least a 50% decrease in the amount of transfusions that they required, for a total response of 76%. So that's a pretty big number, especially in the MDS world. And the time to response was about 4.5 months. And then we'll see that's a pretty consistent thing across all the studies. The median time to response is 4.5 months. On the right-hand side of this slide is the free of transfusions Kaplan-Meier curve. So patients who became transfusion independent, how long did they maintain this response? So the median was not reached, which is always a good thing. And you can see it's a pretty gradual drop. And I want to point out the scale. So those are weeks. So we're looking well into 90 weeks of treatment here. One of the most interesting things about lenalidomide that I think is the fact that we see cytogenetic response. So we'll have an anemic patient. We'll give them an ESA, erythropoiesis stimulating agent, Procrit, darbepoetin, what have you. We don't expect much to happen under the hood. We don't expect the cytogenetics to change necessarily or the molecular mutations to go away, but in fact we do see this with lenalidomide. And that's what the bottom table illustrates. So patients with isolated del(5q), 45% of them had a complete cytogenetic response in this study. And with the additional abnormality, 40% of patients had a complete response. And even patients with complex cytogenetics had a 50% complete cytogenetic remission rate. So pretty impressive. So this was kind of a broader sweep of patients. What about specifically patients that had the label indication MDS? So that's this slightly smaller red box on that guidepost diagram we have. Again, the MDS 004 study addressed this particular population. Again, all these patients were RBC transfusion dependent, so they all had transfusion dependent anemia. And patients were randomized in a 1-to-1-to-1 fashion to either lenalidomide at 10 milligrams a day, lenalidomide at 5 milligrams a day, or placebo. And these patients were followed. There was a couple of analyses done. There was a total population IIT, intention to treat analysis, as well as a modified intention to treat. And one of the key parts of this study is there was crossover. So patients who received placebo did crossover. So some of the time points were a little bit earlier on in this study. But here's kind of the top line result. These are patients who became transfusion independent. Again, transfusion dependent to transfusion independence. And the numbers were pretty similar to what we saw in the MDS 003 study. So as the protocol-defined definition of red cell transfusion independent, 55% patients achieved that on the 10 milligram dose of lenalidomide. And if you look at the IWG criteria for transfusion independence, 60% of those patients achieved transfusion independence as compared to those on 5 and placebo arms. So response duration, again, was quite lengthy. The scale at the bottom of this Kaplan-Meier curve is in weeks. It goes out to 150 weeks. And in fact, the median duration of response was not reached for either lenalidomide 5 milligrams or 10 milligram dose. So again, these responses, when they happen, are quite durable. And just like the MDS 003 study, the MDS 004 study saw a lot of cytogenetic responses. So looking at the column, the lenalidomide 10 milligram column on the far right, 50% of patients had a cytogenetic response. 30% of those were a major response where there was no detectable del(5q, and 20% were a minor response where there was at least a 50% reduction in abnormal metaphases. So again, significant cytogenetic responses in these population. The use of lenalidomide in the MDS 004 study also had a dramatic effect on quality of life in patients, which is important. These patients, the lower risk patients, do live years, and we not only want to lengthen their life, but we also want to increase the quality of their life. And the 12-week time point, they saw a significant improvement in patients' quality of life as measured by the FACT anemia score. That was tested at baseline, again at 12 weeks. And the reason we're focusing on that one there is because that's when the crossover happened for the placebo and 5 milligram patients. So survival was not different amongst the different arms of this particular study. The lenalidomide 10, 5, and placebo curves here all are overlapping. But those who had a cytogenetic response had a better overall survival, as well as those who achieved red cell transfusion independence. So certainly some disease modification effect there, no matter what your definition of disease modification. We're seeing changes in cytogenetics, we're seeing improvement in quality of life, and we're seeing some survival benefit. So how about those with isolated del(5q? So a really specific slice of the pie, and perhaps kind of the one that comes to mind when you think about treatment with lenalidomide in MDS in particular. So the top line of the table here are the red cell transfusion independence. So again, this was the MDS 004 study, the one we just talked about, but what happened here is the group pulled out just the isolated del(5q patients. And you can see that in the 10 milligram dosing of lenalidomide, 57% of patients achieved red cell transfusion independence, as well as 37% of the patients who received 5 milligrams of lenalidomide. Again, very similar rates of cytogenetic response as well. 56% of patients who were treated with lenalidomide 10 milligrams achieved a complete either any form of cytogenetic response. So very similar, whether or not it's just the isolated del(5q or a del(5q with additional abnormalities in this population. Just like the full MDS 004 study, there was no survival advantage compared to placebo, but there was a survival advantage for those who did achieve red cell transfusion independence. So we've been talking now all about patients who have the del(5q abnormality. I think Rami touched on this a little bit ago, but what about patients without del(5q? Can we use lenalidomide in those populations, and what do the outcomes look like? So this is the MDS 005 study. You may sense a pattern here, 003, 004, and 005. But again, the red box has changed here. So we're looking at patients without the del(5q abnormality, but they were still all transfusion dependent, or they were either refractory to ESA, so they've received Procrit or darbepoetin or Aranesp or one of the ESAs, or they were unlikely to respond by ESA as predicted by erythropoietin levels, serum erythropoietin levels. And they were all given 10 milligrams per day of lenalidomide. And on the right-hand side, you'll kind of see the patients that were screened and went through the study. Again, it was a 2-to-1 randomization to placebo versus lenalidomide. Being a more recent study, mutational profiling was done. I would be remiss not to add in some form of mutation alphabet soup in explaining these studies, but most of the patients did have SF3B1 or spliceosome mutations, followed by TET2, ASXL1, and DMT3 alpha mutations. Here is the top-line results from the MDS-005 study. 26.9% of patients who received lenalidomide achieved transfusion independence, compared to 2.5% of those who received placebo. So still, not the degree of patients that we see respond who have the del(5q) abnormality, but still better than placebo for sure, and quite a sizable population. The duration, though, was shorter, and if we look at the curve here, the scale is similar, 120 weeks, but the curve does definitely drop a little bit quicker. And although the median time was not calculated for this, for the placebo arm was, since no one really responded, it wasn't very long. But for the lenalidomide, we are actually able to calculate the median duration of response. It was 30.9 weeks. Whereas in the MDS-004 study, those patients on this time scale responded for so long, the median duration of response was not calculated. There were cytogenetic responses seen, although not to the same degree as in patients with del(5q). A major plus minor response was seen in 33% of patients, and a major response only in 18% of patients. So cytogenetic responses, but not to the degree of the del(5q) population. So I think the pre-test question focused on predictors of response in this particular study. So this is the univariate model and the multivariate model of predictors for response in this particular study. I wanted to highlight here the average baseline transfusion burden. So patients who had low transfusion burden versus those who had a high transfusion was predictive in the univariate model, as well as prior ESA use and having a serum EPO level above 500. However, in the multivariate model, prior ESA use was the only factor that predicted response in this study. Again, this was a priori analysis, but in some ad hoc analysis, they also looked at varying serum EPO levels. And specifically, our pretest question looked at the figure on the left. So this is responses. The blue bar represents responses in patients who had prior ESA use and have a low EPO level, so that's 35% of patients. The yellow bar represents patients who had prior ESA use and an EPO level above 500, and the gray bar is those with no prior ESA use. So clearly some differences there in these different populations, although the numbers are kind of small. And then the figure on the right is an ad hoc analysis that was done after the study was completed, looking at varying EPO levels and responses. And so there was certainly a dose response with pre-treatment EPO level. Those who had very low pre-treatment EPO levels were more likely to respond than those who had very high pre-treatment EPO levels. So all these studies so far have been looking at patients with lower risk MDS. What about those with higher risk MDS? So the GFM study, it was a phase 2 study and really kind of shifted the box over to the right on our little diagram here, looking at high-risk patients who had the del(5q) abnormality. These patients in the study also have a platelet count of greater than 25,000. They received lenalidomide 10 milligrams per day. And on the right is the table of attributes of these patients. 19% of them had isolated del(5q), but 58% of them had del(5q) with 2 or more abnormalities. So a pretty high-risk population. Nonetheless, there were some responses. 27% of patients had a response. 14% had a complete response. There was a marrow response seen in another 4% of patients, and 9% of patients had at least an erythroid response. And there were some cytogenetic responses seen. 10% of those had a major cytogenetic response where the del(5q) abnormality was no longer detectable, and 9% of patients had a minor response. And the curve on the right is the Kaplan-Meier curve of survival. So the median survival in this population for non-responders was 169 days, and for those who had a hematologic response was 560 days, and those who had a hematologic complete response did quite well, and their median survival was not calculated. So P53, I think Rami also mentioned this, the idea of P53 and lenalidomide and some interplay there. And the concept is that lenalidomide does not work forever in patients. And why do patients progress, or why does their disease change over time? And one of the concepts is that there's sensitivity for the particular del(5q) clone. And prior to treatment, there might be small little subclones that have P53 or some sort of resistance mechanism that are not suppressed by the lenalidomide, but then grow up later once the competitive advantage is, the del(5q) clone is removed and there's less competitive advantage. And this one particular study was one of the ones that really highlighted this issue. So they took patients that were lower risk MDS and had the del(5q) abnormality plus or minus other cytogenetic abnormalities, and they did sequencing on these patients. And 18% of patients had a P53 mutation prior to treatment, and with varying variant allele frequencies. So the average variant allele frequency was 11%, but the range was 1 to 54. So those who had a P53 mutation, there were 0 cytogenetic responses, whereas those who had no detectable P53 mutations had a 50% cytogenetic response. So a pretty dramatic difference there in terms of that kind of golden response of cytogenetic remission. There was also differences in evolution to AML. So those who had a P53 mutation, 50% progressed to AML, where over the duration of the study, where those who did not have the P53 mutation, only 16% progressed to AML. And that's represented in the Kaplan-Meier curve at the bottom right-hand corner, blue being those who did not have the P53 mutation, and yellow being the ones who did. The figure in the upper right-hand corner shows a single patient from this study to kind of as an example of how these clones may change. So you can see that the blue line here, once lenalidomide treatment is initiated, drops dramatically, and that's the del(5q), the measurable amount of del(5q). But you can see the yellow and gray curves kind of come up during treatment and not really be affected a whole lot by lenalidomide treatment. And that's really that resistant clone, that P53 clone. So it kind of illustrates, again, the concept of competitive growth and really the sensitivity of the del(5q) clone in it by itself and the relative resistance of those that contain P53 mutations. So one of the concerns, certainly in the myeloma world, is secondary malignancies as well as side effects with treating these patients. One analysis looked at the development of second primary malignancies. This was a pooled analysis from the MDS 001, 2, 3, and 4 studies, included over 500 patients. Interesting, 15% of patients had a prior history of cancer, so you wonder what type of other chip or clonal abnormalities they had elsewhere in their body prior to enrolling on these studies and getting lenalidomide. 28 patients over the duration of these studies developed at least one second primary malignancy, including non-melanoma skin cancers. And the median time to onset of these second primary malignancies was 13.5 months. And the column in the middle of this table is the overall invasive second primary malignancy rate. So the rate per 100 patient years was about 2.6 for this pooled analysis. And then when you look at SEER, a large national database, the population incidence for patients over the age of 65, just for malignancies in general, is 2.1. So they're very, very similar. So these results suggest that in patients with MDS who do receive lenalidomide, there's no increased risk for second primary malignancies. This is a table of common adverse events, but really the thing we kind of focus on often in the clinic is neutropenia and thrombocytopenia. These are very, very common. Neutropenia occurs in 60 to 75% of patients, and thrombocytopenia in 44 to 60% of patients. And you kind of sometimes have to finagle things a little bit, especially early on in treatment when you're cleaning out that del(5q) clone in terms of either stopping treatment periodically or reducing the dose. And again, the table on the right are common adverse events. The one that's probably most common and can be really sticks out in my mind as something difficult to treat in the clinic is actually some of the pruritus, and I've had a few patients who had quite a bit of difficulty with that. So kind of putting it all together very quickly, this is certainly not as elaborate as Rami's figure, but when you have a patient with isolated cytopenias, and particularly their cytopenia is anemia, and they're either not unlikely to respond or have already had an ESA, lenalidomide can be considered, particularly in those patients who had the del5q cytogenetic abnormality. So there are a lot of remaining questions. I'm sure Dr. Zazern will answer many of these, but particularly combination therapy is a natural next step of single agent lenalidomide therapy. And this has been done and is still being explored. One common logical combination would be with hypomethylene agents, and this was explored in the SWOG S1117 intergroup study, where azacitidine was compared to azacitidine plus lenalidomide and azacitidine plus vorinostat. The overall response rates comparing azacitidine plus len versus aza alone, the overall response rates were a little bit higher for azacitidine plus lenalidomide, but the median survival was not different in those two randomized populations. Another combination, Rami brought up this particular study, the E2905 intergroup study, looking at lenalidomide plus ESAs, and there was clearly an interesting and positive result for the combination in terms of major erythroid response and overall erythroid response. And the other big question is the P53 people. Patients with this particular mutation, what do we do with them? The response rates with lenalidomide are not great. They do respond with erythroid responses in anecdotal situations, but it's not often long-lived, and we need to find new and better treatments for those patients in general. So I'd like to thank you for your attention, and if we have time, maybe a question or two.